Thank you, everyone, including chairpersons, for their presence in this talk. My presentation is actually to explore what happens to PTPD and what is going to happen to endoscopic ultrasound guided biliary drainage as it is evolving. I need to, at this stage, because we are talking about comparing an evolving modality with something that is established, I like to keep things a little open, and it's not just a simple head-to-head comparison. So, I think what is in everybody's mind is what is the current indication for endoscopic ultrasound biliary drainage. Now, first thing that pops up is a primary failed ERCP. That means ERCP fails despite good anatomy due to some technical reason. Then, of course, you have surgically altered anatomy where the ERCP failed re-intervention. That is, you have a stent in place within the bile duct, there's a tumor there, you can't go back in and another stent if there is a re-obstruction. So these are some of the current situations where one considers using a US. Now, contraindications, because coagulopathy and ascites are there. So, with respect to PTPD, what is the current status of PTPD? It is, funnily enough, the indications for PTPD are exactly the same currently. So it is like US is just coming and occupying the exact indications for PTPD right now in clinical practice. Again, when you talk about PTPD, you talk about failed ERCP, surgically altered anatomy, and all these things. And interestingly, because both these modalities, that is the EUS as well as PTPD, involves the liver puncture, which is not there in ERCP. Issues of coagulopathy, ascites, common to both of them. But of course, one thing that we must not forget at this point is that PTPD has got a particular strength in hilar strictures, and I think we'll elaborate it in a moment. This is a cartoon I have basically borrowed from the pointer. Oh, this is a pointer. Okay. See, oh, right. Okay. So there are different types of US procedures based on how you approach it. So you can either have hepatic gastrostomy, where you connect the nerve system to the stomach like that with a stent, or you can approach through the duodenum, making it a duodenostomy, where you basically approach the posterior duct, the right posterior duct, through a lateral aspect of the duodenum, usually the bulb. Now, if you look at this diagram where we have a diagrammatic representation of the hilar stricture here, it is obvious to us that any duct can be easily accessed by a percutaneous approach. So the ability to selectively puncture selective ducts in a situation like this from outside is a natural advantage that we have with PTPD. But the one advantage that that EUS has vis-a-vis both ERCP and PTPD is that in both ERCP and PTPD, one has to cross the stricture to give the patient internal drainage. Here, that is not required. You don't have to cross the stricture. You just connect this, you're far away from the stricture, and you get drainage. And because you're far away from the stricture, you are likely to have a much greater patency and issues with tumor ingrowth and overgrowth and all. That's not going to happen. So this is a natural advantage. What is like an external drainage in PTPD is actually an internal drainage in US. So that's a great advantage. But of course, this approach, this is the easiest way you can do US guidance. That is, approach the left system. Right system is more challenging. This approach is actually more challenging. So many times when you have to drain the right system, you may have to cross and put in a stent from the right to left, which is called a bridging technique. But all that is technically very challenging, but that's how we do it. Or the best way is to do combined ERCP, and so you just put in this stent with the US and then do the rest of it with the ERCP, so you get drainage of both sides. But the point I wanted to highlight was the ability of PTBD to access any of these ducts as you please. And sometimes in hyaluronic carcinoma, you do not want to inject into certain systems. You just want to drain it. So I have specifically used the literature in parenthesis because this may not exactly be the way we actually practice. But if you look at PTBD status overall with regard to ERCP, it has got advantage in hyaluronic structures where you have higher rates of clinical and technical success in ERCP and lower rates of cholangitis, even in fairly recent reviews. But where we actually use it is when you have a failure of ERCP again. And bismuth 3 and 4, that means isolation of right and left systems, or segmental isolation is when you use this. When you have a great advantage, like I said, in selecting these ducts according to your wish, you also ensure that you don't unnecessarily inject contrast and produce any kind of cholangitis in these kind of things. Plus the stability, pushability, and ability to cross the structure is much better from outside, or rather from percutaneous route when you have hyaluronic. So those advantages are very much there. But now we look at how PTBD compares with EUSBD head to head. There have been several reviews, actually. This one is in 2017, very widely quoted, and this is something that has come up in 2022. And this 22 systematic review actually deals only with obstructed distal malignant biliary strictures. Okay, so when you have this is just a representative image, and you can see pancreatic cancer with a double deck sign and all that. And it makes it so easy for EUS to actually just put a stent from the left system onto the stomach. Don't go anywhere near the stricture. And so that's exactly what we have. When you actually look at this data, it shows that for distal biliary strictures, PTBD versus endoscopic ultrasound, technical and clinical success rates are equal. Procedural adverse effects are considered to be more for PTBD because of issues like pain usually. Most of the patients actually have pain as an issue. And delayed adverse effects regarding recurrent biliary obstruction sepsis and all that was not much, because many of these patients, the life expectancy is only about 3-4 months, so it doesn't really matter so much. So overall, you see that it's very positive for EUSP, and plus one great advantage is that if you want to switch from ERCP to EUSPD, you just do it on the same table. You just take out the scope, put in another one, and you can do it. On the other hand, a PTBD means going to another department. It's a different setting altogether. Now, what about hylar structure? There are not too many large studies and meta-analysis and all that. So I just want to quote this recent article from Korea, in which they have done 42 patients, and all they were out of 44, 18 patients went for PTBD, 24 for US. And all of them had a stent in place, which was put in by ERCP, and it was occluded, and they had to provide drainage. That was the clinical situation. The technical success was, as you can see, almost the same, exactly as we found in the previous study. And early adverse reactions, they said that usually pain is actually more, definitely for PTBD, but not statistically very significant. But what was statistically significant was that the median duration of patency of the stent was actually higher for EUSP. Now, I want you to note this. These are some of the issues here. They used covered stents, 6 mm for all patients. And basically, if you were to put the stent like this towards the duodenal bulb into the BD, you can see if it's a covered stent, it will block this duct and produce cholangitis. So you need this portion of the stent to actually be open. So these are things that are still evolving. And because another problem with using covered stent is that covered stents tend to slip out much easier than bare stents. So these sort of issues still need to be tackled. And in these patients, just to make sure that the comparison is perfect, they did all PTBDs to the posterior duct. But the point is, with PTPD actually, the advantage is you can actually train any duct or you can do multiple ducts also. And training the anterior system from this position with EUS is still a bit of a challenge. But for PTPD, that problem is not there. But the point I'm making is overall, even in places where they don't have much experience, they're all evolving, the comparison is very good. It's just about as good as PTPD with some advantages. So if I were to put everything in a chart and see this, no, you have PTPD here, ERCP here, and endoscopy ultrasound here. Let us look at the advantages. It's a new and evolving technique, number one. These two are very well established. Here, like I said, there is no, you don't have to process the structure multiple times. I mean, you may have to many times, you can do it antegrade or a rendezvous and all that. But you can get away with without crossing the structure. Here, crossing the structure is important in these. There is no liver puncture in this, in ERCP. That's a great advantage. And in PTPD, the multi-duct access from outside is also an advantage. The other two techniques. There's no external catheter here at the end of the procedure, no external catheter here. We have external catheter here. Okay. Now, no adverse events is what is being reported now. And this is very important. The switch from ERCP to EUS you can do seamlessly. And of course, this is the most important thing. 95% of biliary drainages today are done by this, whether you like it or not. And this, another advantage here, we are not translumen. We are not going from the lumen with infection into the duct. So there is a theoretical advantage here. And we have to admit it, when you have a frank cholangitis, this is the only technique that gets the bile out of the liver quickly within a day. On the other hand, both these two will end up draining within the system. So there is something about PTPD which, regarding its ability in the hilum as well as the ability to completely clear cholangitis in a very short frame of time. That's an advantage. Disadvantages are also interesting. Right system is a challenge in the EUS today because of experience and also material is not there probably. So peripheral duct obstruction when you use a covered stent, multi-duct is an issue on the right side. Then ascites and coagulopathy. Like I said, these two procedures actually have a liver puncture. So ascites and coagulopathy are terribly important, which is why we are forced to use covered stents and all that in the US. Pancreatitis is a unique problem with ERCP which you don't have in diabetes. And of course, in PTPD, if you end up with an external catheter, that is not something patient likes. So that is an issue. So it's a mixed bag, and if you want to put everything in context, I would say that essentially there are some great advantages with the EUS. If you have a failed ERCP situation, the switch to EUS will be very easy. But if you want to, in that situation, drain the right side, you're talking about a much more difficult procedure. And if you want to drain more than one duct, it's particularly problematic in the current situation. And either you have to go bridging from the left to the right, or you will have to use multiple drainages, accessing the right and the right proceeding systems. It's not very easy at all. But if it's a simple lower CVD obstruction, there is no doubt in a situation like that, the EUS is far better than PTPD. You can just switch to the table and just putting a stent into the left system is solved. So, summary is an emerging, limited experience and evolving. And new devices are what are evolving, which are going to make it easier and safer to do EUS. There's still early days for us when saying data, comparisons and all that, not premature, I would say. And it's already an accepted choice in failed ERCP in left system drainage, like I was explaining why that is so. And the right system and multi-duct drainage is a work in progress for EUS regarding what kind of material, what kind of stents they will use, all that. Ultimately, I think a few years down the line, we won't be debating EUS with PTPD and ERCP failure. We'll be debating EUS versus ERCP itself as a primary biliary drainage thing. So that is what is going to happen. And that is something that I don't think it's the way the industry moves, it's the way the technology moves. But I think one thing that I want to just point out here is there is a problem when this sort of thing happens, when you have a replacement in a disruption, there is something called, there is an atrophy of support techniques. So if ERCP tomorrow becomes a support, PTPD is a support, and you do those things very infrequently, your skill sets go down. And when you want these procedures, you need, generally they are very difficult situations. You want somebody to do it in 15 minutes. That may not. So it's like you can't have the cake and eat it too, that kind of situation. Anyway, I think thank you for your patient listening and for your presence. Thank you. Correct. Correct. Right. Actually, one thing I did go through it. For the first 2 week adverse effects and the adverse effects after that. Many of them don't address this issue at all. This is a very relevant issue. You don't want bile to be leaking into the stomach of all places, but it's never just papered over or swept under the carpet. Yeah, because I also have limited experience with the whole thing, so I was also wondering exactly what you are asking. But it is not addressed in these many of these so-called like meta-analysis and systematic possibly. Right, right. Yeah, that's right. It looks very simple. Technically, it's very simple. And the fact that you don't have to process